Now go on to our next speaker, Dr. SRIVASTAVA, a young dynamic surgeon from Raghudeep Eye Hospital, Ahmedabad, and also has his own standalone practice in Jaipur. And he showed us around his clinic, which is so amazingly nice. And he has been a winner of innumerable awards at the international level and has always great content to show and teach. On to you, Samaresh.
Hi, Samaresh.
Yes,
good
evening, madam.
Yeah.
Thanks a lot for the lovely introduction, madam. And it's my honor to be a part of this program. And I'm sorry once again for a delayed video that I sent. So I'm going to discuss a case. So this is quite similar to the first case that we discussed today by Dr. Subhash Prasad. I have a patient with toric IOL. Now, these are one of those cataracts which are neither here nor there cataracts. They're not very dense. And at the same time, they're not very soft. So you're not sure whether you want to chop or you want to do a 4-quadrant. So I did a chop maneuver in this patient, but then I realized that the chop wasn't complete. So I shifted my gaze from chop parameters to a 4-quadrant parameters where I reduced my flow rate, very low flow rate, and I'm playing with right now of about 8 to 10. And I'm trying to ease out that posterior plate that was stuck in over there. Sometimes it's very difficult to visualize, especially in these cortical cataracts. So once I saw that it was gone, the posterior plate was cracked, I decided to remove the fragments. But while I was removing my first fragment, I could see an area of clearing. And for all the surgeons out there, you know how, the kind of sinking feeling you get when you see this sort of a picture, when the posterior capsule is clearer than it should be. And it's pretty evident over here that there is something that has gone wrong in this area, which is visible over here, which is quite evidently an open posterior capsule. When a situation like this arises, I think it's our duty and responsibility to first identify the vitreous. And having identified this, I think for us, for now, for the last almost about 6-7 years, our go-to choice is to do a pars plana vitrectomy. So we have a limbal irrigation and we have a vitrectomy probe through a trocar cannula system where I'm underneath the posterior capsule, clearing up the vitreous, preventing it from prolapsing anteriorly. And I'm using the irrigation anteriorly to keep the anterior chamber stabilized. The idea for vitrectomy for me is not to do a core vitrectomy, but just to clear up the area in the posterior capsule opening so that I have now enough maneuverability in that area because my incision is temporal and I have to remove this nuclear fragment. So one of the choices I had was to make another incision and suture this, but I decided to go ahead in the same area. But because with the newer machines, particularly with torsional platforms and good followability, there is now distinct advantage of having that nucleus which is always going to stay close to the probe. So notice I've split my irrigation and my phaco. My irrigation is not a part of my phaco probe, but my irrigation is in my left hand. But the phaco probe is just removing. It's just emulsifying and removing. And I'm using irrigation to keep the anterior chamber flat. And I'm using the fluid waves over here, which is my manual irrigation, to bring the nuclear fragment right onto the phaco probe. And with good torsional and good followability and moderate parameters, good knowledge of machine, I'm able to make sure that the entire 3 quadrants of the nucleus, which was lying in the capsule inside the capsular bag, was removed without having any fragment drop down into the posterior cavity. And I could do that because of splitting my irrigation and my phaco probe. Now, like the previous surgery we discussed, I put a toric IOL, I dialed it into place inside the capsular bag by enlarging the incision and going slow with the manual delivery. But I decided to do a reverse optic capture in this, where the optics or the haptic is inside the capsular bag, but the optic is prolapsed out of the anterior capsular margin so as to lock the lens into place and make sure that it's dead stable and does not tilt, decenter, dislocate later in life. Just to make sure, it is important to make sure that there's no vitreous left behind. So I use diluted triamcinolone in the anterior chamber to look out for remnants of any vitreous. It's also needless to say, you have to suture these incisions because there's a situation of compromise. And I prefer to use 1 or 2 sutures on my main incision. I'm removing whatever little viscoelastic was remaining behind and also removing the triamcinolone. Again, whatever triamcinolone is left behind in the anterior and posterior compartments, if at all, is going to prevent further inflammation. It's also a good idea to hydrate your incisions with your irrigation in place. Because the moment you remove the irrigation, the entire lens tends to luxate anteriorly, and that can cause your, if at all you've done an optic capture, to slip out. So I keep my irrigation in place, hydrate the side port, and once I know that my chamber is formed, and hydrate the main port also, then I will remove the irrigation from the bimanual IA out of the eye. Because when 2 out of 3 incisions are tight, the chamber will not collapse and I will have a solid, stable anterior chamber. And notice now I'm removing my, finally I remove my the irrigation probe, which was working like an AC maintainer. So this is how the patient looks at the end of the surgery. I'm just trying to check the lip of the wound, and this is how the patient looks a few days after the surgery. Yeah, this is the follow-up 6-9 and 6-month follow-up, well settled 6-9 unaided patient, and a very happy outcome for a very unfortunate incident that happened intraoperatively.
So,
Wonderful, wonderful video, Samaresh. Lot of learning and truly amazing. But I have some questions for you. Could you stop sharing your screen?
I stopped.
Oh, see you. Yeah. So the you
Yeah,
have
the screen share is stopped now, madam. Is it?
yes.
Yeah, stop. Very nice video.
very nice. Yeah,
Thank you.
Samaresh, what I wanted to ask you was, rather I will ask the expert panel. You are all waiting to be challenged. Now, when you see a new PCR there and the nucleus in the capsular bag, the first thing which all of us would think is to get the nuclear pieces out of the bag and then attend.
There is, I think, some problem with her net, as she has said.
Doing a past plane with me. Could you all hear what I said?
No, actually,
Could you
there
hear?
was some problem with your net. That
Yeah, no problem.
No, what I wanted to say was that normally we would have liked to remove the nuclear fragment out when the PCR is there, gently, carefully, but he let the nucleus be in the capsular bag and went to do a pars plana vitrectomy. Okay, let me start with Mohan. What would you think?
No, I think exactly right. This is a fantastic message I want to give everybody. When you have a PCR, don't be in a hurry to pull out the phaco probe, number one. Fill up with the viscode. And as soon as you fill it up with viscode, obviously the vitreous is going to be there. Put tricot first. Stain the vitreous and do a bimanual anterior vitrectomy, or you can go posterior vitrectomy as whatever you're comfortable with. But remove the vitreous first. Then fill that area with viscode, and then you can go ahead with the removal of the nucleus, as what he did. This is exactly. Don't be in a hurry to remove the nucleus in the presence of vitreous in the anterior chamber. That is going to cause more problems in the long run. Traction on the vitreous base, retinal detachment, retinal breaks, all these problems can occur. Samaresh, beautiful video, very beautiful teaching video.
Dr. Agarwal, Virendra Agarwal, are you there? Dr. Virendra Agarwal, are you there? Okay.
Yes, I am here.
Yeah, Dr. Virendra, would you have thought of using a IOL scaffold in this particular case? Would you have done a vitrectomy, got the nuclear fragment forward, placed the IOL in the sulcus, and then completed? Because you can never be sure whether some of the epinucleus could go into the vitreous at this point of time. Could you have handled it a little differently, or would you do exactly the way he did?
This way is also very good, and you can handle by IOL scaffold also is very good. But the issue is the IOL scaffold is the 3-piece. So toricity is not there. That is the one big issue right now we are having. So if you want to really implant and need to implant the toric lenses, then you cannot use the IOL scaffold the way you want. And there is no sense in using 3-piece and cut it and out, take it out, and then use the toric lenses just for scaffolding. So this is nicely managed. And good message is that the vitreous need to be respected. Vitreous need to be managed before doing further maneuvers. Because if you maneuver with the vitreous in AC, then you will enlarge the tear. You will have more of the products of the vitreous. So vitreous need to be addressed first. That is very, very important. Here I want to add on. I want to add on my experience with some of the lenses which are having optic haptic angulations. I am putting them in the sulcus and having the optic capture as a 3-piece lens, and touch wood, till now I didn't have any complications. But this cannot be done with the lenses which are not having angulation, like some of the companies have. The plane lens means the optics and optics are at the same plane. In those cases, you can do a reverse capture. But I still feel if you have something like an option of optic haptic angulation toric lens, then in these situations, they'll serve better.
I'm not aware of which single piece lens comes with the toric lens coming on an optic haptic.
From the biotech company and from the Johnson & Johnson, both are having angulation. single piece lenses.
5
One
days.
is having 5-degree angulation, one is 6-degree angulation.
Okay.
Chitra, can I add
No
one thing?
financial interest.
Yes, Mohan.
Yeah. Samaresh, I think the removal of the nucleus with an irrigation separately, I'm not sure because, see, once you remove the vitreous there, okay, and you put viscoat, right?
Yes.
And use a low flow rate and low, of course, Centurion, you have the advantage of active fluidics. So you can reduce the IOP to as less as 20 or 30 and go ahead with the beautiful removal of the nucleus without disturbing, because once you have removed the vitreous, the tear is not going to enlarge at all. And the viscoat will go on a scaffold that prevent that this thing from going at. I don't find any sense for the separate irrigation because you're going to heat up the phaco tip there, okay? Because there's no irrigation there, no?
So what the reason I did it is because the PCR was right in the area of the phaco area, and the irrigation currents were going in that direction only. So by removing the irrigation, I dissociated the flow of fluid in that area.
Yeah, I got your point. But when you're doing the phaco, there is no irrigation through the phaco tip.
No, so but there is aspiration happening. The phaco-propyl get heated up if there is no aspiration happening and there is occlusion at the phaco tip. But so long as material is flowing through the phaco tip, the fluid going out will cool the phaco tip at the same time. So heating generally will happen when which is blocked it.
Yes.
Mohan, when you use the separate irrigation, you had some advantage. It works like a third instrument in which you can have the flow over the iris plane level or above the axis. So it is not disturbing the vitreous. That is one big thing. He has done good way. The second thing, the case was very soft. So even you don't require a phaco power. So in which case that you don't think about the phaco burn or the tip getting heated. And once fluid is there, which is moving, definitely burn is not an issue or the heating of the tip is not the issue. Viscot is really a big thing for this kind of things to plug in the area of defect. So that is a one good thing. Methyl cellulose is not enough. So you have to use
viscot is the
viscot or some, yeah.
And of course, Chitra rightly said, IOL scaffold has got a huge role in this particular situation.
Yes.
I would have done an IOL scaffold also because, but please make sure, okay, of course, if the toric lens is a different issue, multi-piece you have to put, but IOL scaffold, don't do it in the absence of, without doing a vitrectomy or removing because sometimes it's very difficult to remove the nucleus and epinucleus and the cortex also. So make sure that if you remove the vitreous and everything, clear up that area, then you can put an IOL scaffold.
Dr. Rajan, there is one more point I want to add.
Yes.
When you are doing the last part and you're worried about removing the irrigation port and chamber collapse. So once the eye is vitrectomized, you can, what we do in fluid gas exchange in retina surgery, we can do same thing in anterior part also. So you put an air bubble and that air bubble takes care of the space and the eye does not collapse. I have tried it many times. And believe me, air is not as harmful to endothelium as has been mentioned. So I think if there is an issue of wound leak or if you're not sure about the chamber stability, inject air. It gives you a lot of stability and time, and then you can do hydrodissection to the wound, and your chamber gets stable.
Okay. So there were different thoughts. So thanks a lot, Samdesh. Extremely good teaching video. Need a real big